Hello, good morning to you guys. Good afternoon to people here, and then good night to Dr. Dubase. He's still hanging on. It's nice to see. I want to congratulate everybody on this program. I think it's a great course. I've been on all morning, and I'm learning a lot. And I look forward to doing this in person, hopefully next year. So my task is pretty daunting. Talk about revision spine surgery in 20 minutes, but I want to give you some pointers and hopefully you will learn something and we'll exchange information. The problem with adult spinal deformity is a very humbling specialty, has a high complication rate, and there's a lot of failures in all planes. And the revision rates, if you look at the literature, vary from 8% to 58%, depending on who's doing it and who's reporting it. And it can vary from the initial surgery not being done right, maybe some persistent symptoms, and then the progression of the disease, obviously. So for the patient and the surgeon, it's a real failure. There's a lot of risk involved. There's a lot of expense involved, especially nowadays we're looking at expense. There's a cost of to the patient from significant time away from work, and not to mention the anxiety and the psychological aspects for having additional surgery. The pseudoarthroses are still very common. Curve progression, infection, of course, the list goes on. Implants, adjacent segment, implant failure, neurologic deficit, and coronal imbalance. They all are there. And the challenges are that not only do you have to address if you have any junctional disease, but if you have malalignment in the coronal sagittal plane, you have to fix that. Otherwise, it's just going to keep going on and on. And you have to take out the instrumentation, you have to revise it. And now there's hundreds of systems. So just to have the right equipment to take the system out is a hassle. And then repairing the non-union after you've done surgery on somebody, the scar tissue prevents you from having a successful union. So you have to think about supplementing it anteriorly to a fresh place. And then revising poor or coronal or sagittal plane reconstruction adds another factor to this. So of course you start with some coronal radiographs and look at the plumb line where it lies. You look at the listhesis of vertebrae, especially in the lumbar spine, how oblique they are, how displaced they are, how much lateral listhesis there is. And then you have to look at the sagittal plane, looking at all the regional curves, pelvic parameters, et cetera, et cetera. But I think we mentioned this before is the supine radiograph. I think there's a lot of value to the supine radiograph. I use it all the time. And if you look at this patient who looks like she has a long sagittal malalignment from the thoracic spine, as soon as you lie her down, that improves significantly. And I think Dr. Dubase and Larry mentioned both of them. So this makes your job a lot easier when you're going to think about realigning them. And then not to mention, even if you use the ADIS classification, you have to add the MRIs to these patients because frequently they'll have neurologic problems, very different from an adolescent idiopathic scoliosis. You have to look at the facet joints. You have to look at the levels that are stenosed so you can decompress them and make that part of your treatment. CT scans are invaluable in these cases because I look at the CT scan as one more way to look at the spine because the X-ray does not show that. So you can look at where the ankylosis is, where the non-unions are the screws in the right place because you are going to be replacing the screws. And I will frequently do CT scans on all these revision patients to really evaluate that. So here you can see the non-union area. So you know that you'll be able to cut through that and get some motion. And then you see some areas that are fused and you know you can't depend on any motion, especially like here at L45, you will not get a motion. So you have to put that in your plan. And of course, bone quality is equally important. Anybody with osteoporosis, and this is very frequent, you have to put them on some anabolic hormones like Forteo or Timlos to get that fixed, because the bone is going to be your weakest link, and it may affect the quality of your fixation. So what are the strategies for correction? Well, from simple to complex, posterior only, wide releases, some sort of lateral or posterior lumbar interbody fusion, laterally doing MIS, or posteriorly doing Smith-Peterson osteotomies. And then finally, I think Winshaw had a great talk on anterior release. I think an anterior release is coming back in fashion. It went away for a while, but it is a truly powerful tool in getting correction on these deformities. And then finally, if the patient is completely fused and that's not a possibility, then a pedicle subtraction osteotomy comes into play. All my pedicle subtraction osteotomies are usually in fused spines. And then vertebral column resection is absolutely the last resort in these cases. So let's start with some simple cases with some simple lessons. So let's say this patient had a previous L2 to 5 fusion, then had a fusion from L5S1 because the L5S1 disc space degenerated. Now, what you don't see is there's no interbody fusion L5S1. So they're trying to rely on extending the fusion without interbody or distal fixation, which can be a problem. And they come in, and you will see on the CAT scan, the screws are loose. There's a non-union L5S1. The solution is simple, but you need to work this up with a CAT scan to find out. So the anterior interbody in this case is absolutely valuable, and you have to revise those sacral screws and add in distal fixation, and that's what we did. And that very simple solution makes a very good result. And we actually published this a long time ago. This was talking about the sacral screw, how if you add on this graph a distal fixation, the strain on the S1 screw decreases by 70%. Now, if you add anterior, some sort of interbody, it only decreased by 30%. So just remember that. Distal fixation decreased the moment on the S1 screw by 70%. So use distal fixation whenever you're going to the sacrum. So getting back to this case, so from simple to absurd, so it looks like you have coronal malalignment. The other thing here to learn is that don't stop at the apices of scoliosis and don't stop at the apices of kyphosis. So in this case, this rule was violated and they stopped at the apex of the lumbar curve. So this is what she looks like. Of course, now she's trying to get better alignment by bending the knees and look forward. So she does have the sagittal malalignment. And when you do a supine x-ray, the thoracic spine really straightens out. And this is a good lesson from a case like this, or any case where you're considering adult reconstruction, is to do a supine coronal and sagittal x-ray. And you can see the CT scan I showed you before. And, look at this L4 screw, it's out. Now, when you go back in there, if you don't know that was out, you might be looking at that track and feeling nothing. So I think the more information you have, the better. So we simply reconstructed her with the posterior osteotomies, and then reconstructed the thoracic spine without doing any T-lifts, PLIFs, VCR, PSO, what have you. And you can see that we were able to fix the coronal plane as well as the sagittal plane. Not perfect, but much better. What about this case? This patient also has coronal malalignment, degenerative condition above, and this patient only had this one level fusion, and you can see that the entire deformity was sort of ignored, and she had worsening pain. So if you do a supine x-ray, you can see that the alignment has improved significantly, and there's no real malalignment in the sagittal plane. So this is the standing x-ray, and then this is what she looks like. She's malaligned. in the coronal plane. So we also use bending x-rays and also push-prone x-rays that were piloted here by Dr. Bridwell to tell us what it looks like. So she had a posterior only with Smith-Peterson osteotomies to realign not only in the coronal plane, but the sagittal plane. And this is what she looks like when she stands up clinically. What about this patient? This is a very typical patient that comes to the office. They start with the lumbosacral fusion. They keep extending above, higher and higher, and then they get proximal junctional kyphosis at the thoracolumbar junction with severe kyphosis at the thoracolumbar junction and non-unions. So you can see that pretty significant junctional failure. So you can see how they're trying to stand up like a flat back. And then when you lie them down, there's significant correction of this kyphosis. And this happens most of the time when you look at these patients. And most of the time, you need just a Smith-Peterson osteotomy through that level. The CT scan also adds valuable information. There was bone in the canal. They use cement to anchor these screws, so you have to deal with that as well. But you can see that even if you took care of that, you still end up with a flat spine. So this patient, I think, is a perfect candidate for a pedicle subtraction osteotomy to realign the sagittal plane in terms of the kyphosis and also the PJK. What about this patient? So this patient had multiple surgeries in the lumbar spine, and you can see that the lumbar spine is pretty flat, and the apex of the lordosis actually is in the lower thoracolumbar junction. And in this manner, there's complete disruption of the normal sagittal alignment. So previously fused, malaligned, look at the CT scan, you can see that the fusion is there, but fusion is in a malaligned place. So in order to realign and get the apices in the right place, you'll have to do an osteotomy. And also what you learn is that this was a congenital anomaly because you can see the vertebrae are very narrow, and this is what a congenital anomaly looks like. So maybe they failed to recognize that, and they did multiple anterior and posterior procedures. So she needed an osteotomy through L4 to get that lumbosacral alignment to realign the thoracic spine, because you need to get the lumbar lordosis in the right place, get the apex of the lumbar lordosis in the right place, so the thoracic spine can have a compensatory realignment of kyphosis. And that's what she looks like clinically. And you can see that now the alignment has been completely improved. How about the coronal and sagittal plane malalignment? So if we have a combination of this, you can see that the instrumentation is broken, the morphine pump doesn't help, smoker. And, you know, I think this has been published over and over again. Where do these fractures and failures occur? The lumbosacral junction and the thoracolumbar junction. But the most critical part is that most of these fractures occur after 3 years. So rod failures occur after 3 years, 40% of the time. And that's something that we have to deal with long term. We actually published on this in 2018, 526 patients. And what we found was there was an 18% rod failure rate and 37 were bilateral. And so the greatest risk was the preoperative sagittal imbalance and then thoracolumbar kyphosis. And the longer the fusion, the worse chance you have. So how do you treat these patients? Because this patient already had an anterior and posterior fusion. So those ideas of getting intradiscal or Smith-Peterson osteotomy correction will not apply. So you need to use a pedicle subtraction osteotomy in this case. So that was done at L3 to get the correction. And the 4 rods help create additional fixation around the osteotomy so there's less failure, but you can see how you can correct the coronal and the sagittal plane with an asymmetric osteotomy. That's the clinical picture. What about this case? Now, this patient had a fusion from basically upper cervical spine all the way to the pelvis. And you can see that she's not only malaligned coronally with a flat lumbar spine, but also in the coronal plane, you can see the malalignment with the sagittal plane and the coronal plane. So just to show you the case, she had this picture, and the head was actually going through the bars on the OSI table. So we opened it up, and she did not have a break in the rods. These were actually two different systems they used. So we had to remove all that, and then find the canal and get big resection of the dura. I'm sorry, the resection of the bone to make sure that we have ample space to get our correction. So these are the temporary rods you can use while you're doing the pedicle subtraction, and then you can close it. And then once you close it, you can anchor them on with these small rods and just lock it in place. Once you've locked it in place, then you can work on doing the reconstruction with the long rods, and nothing is moving around the osteotomy. So it's a very safe technique. Plus, it adds additional stability around the osteotomy to make sure that heals. So you can see now that we were able to get some coronal correction with the asymmetric osteotomy, as well as the sagittal plane. We were able to correct that flat lumbar spine to a lordotic lumbar spine. And clinically, you can see that she was on the pre-op here, and then the post-op, and then also on the post-op sagittal plane, she was much better. What about this case? So this patient also has a coronal malalignment. It's a very fixed spine. And then she had this MIS done for the localized decompression and fusion, but the large deformity still remains. And there's a large coronal and sagittal malalignment, and it's quite fixed. So you can see the amount of coronal malalignment there is. So if you do a supine X-ray, it doesn't move. You can see that the thoracolumbar curve does move, but that's the correction you're going to be able to get. But the problem, the crux of the situation is that right here at L3-4, it's fixed in this position, and it will not let you bring the coronal malalignment in place because of this. So that was the problem in this case. And if you actually look, this was done MIS, but some of the screws are not in place. So this pedicle does not have a screw in it at all. So in this case, you can use a vertebral column resection where you do temporary rods, and then you do the vertebral column resection, realign it, and then you do the longer rods to realign the coronal plane as well as the sagittal plane. And you can see the result after that. So not perfect, but a lot better. And you can see the coronal and the sagittal plane on the clinical photos. So how about adjacent level degeneration? I think this is also a very common problem for adult idiopathic scoliosis patients who've had previous fusions in the thoracic spine into the lumbar spine. And when they turn 40s or 50s, they come back with pain in their lower back because they're always degenerated and fused and possibly have stenosis there. So this is a case like that where you have degeneration of the lumbar spine. And I think if you wanted to get a fusion here, you have to pay attention to getting a good fusion. This is a paper from Minnesota where they looked at distal fixation. And if you just use S1 screws and no iliac screws, your pseudoarthrosis rate is much higher. So, and even with the S1 and iliac screws, the pseudoarthrosis were about 20%. And these are mostly having all anterior fusion as well. So in this case, an anterior fusion and a posterior reconstruction to realign the spine is absolutely valuable. And, if you see a case like this, you think about, well, I need to do a PSO, but just imagine when they were young and they had this done, They were not like this. This all happened because they degenerated their facets, they degenerated their disc spaces, and they developed this coronal and sagittal malalignment. So I think your goal is to recreate the disc spaces while they were in the when they were young. So you have to realign the spine by doing intradiscal fusion, like Vincent showed. And if you get a supine X-ray, you get a view of that. In this case, looks like there's some ankylosis between 3 and 4. You can see the osteophyte here that's bridged. And somebody asked this question about, can you break that? Yes. When you go in the front, you can take an osteotome through that. When you do it from the back, it's a little bit more difficult because there's some big vessels there, and it's a little bit daunting to try to get that with the big vein there. But this is the patient clinically really leaning forward and to the left. You can see that. So this was done with an anterior release and a posterior, some not only laminectomies for the stenosis, but also Smith-Peterson osteotomies through those levels to realign the spine in the coronal plane as well as the sagittal plane. And this is where I think the anterior approach really shines. You can see the realignment after the anterior and posterior approach. So what about these revision patients that we're going to be operating on? This was a paper done by Mike Kelly, and he showed that the repeat revision rate on these revisions is 21%. And a lot of them, a third of them, had repeat revisions with multiple unplanned surgeries. So I think you have to be careful when you start doing revision adult deformity surgery. And pseudoarthrosis is still a very big problem. But even when you did all this, the patient-reported outcomes were quite good. And just remember, in repeat revision, pseudoarthrosis, implant problems are still almost 50% of the problem. So try to get a really, really good fusion when you do this by working in virgin areas like the front. So how do you prevent revisions? I think you preserve the stability of the spine when you decompress. So you have enough area to do a fusion. I think most people don't pay attention to do a good facet fusion or posterolateral gutter fusion, which is absolutely important. And then restore the sagittal balance. I think the sagittal balance issues are worse than coronal issues in some of these patients. And they seem to be the predominant reason they come to see people like me for revisions. And let's say you do align them sagittally. If you do get adjacent level degeneration, it's much easier to treat by adding instrumentation and fusion rather than trying to redo the whole thing again. And then if you're going to extend it up, then you have to do the PSO at that time. So try to restore the sagittal plane in the beginning. So I think in conclusion or summary, I would say that study the radiographs properly, do supine radiographs because they will really help you sort of guide your surgical approach. MRIs and CAT scans are absolutely valuable in looking at where the pseudoarthroses are, how the instrumentation has been placed, was there any misplacement of screws, which you have to revise, and then shorten the spinal column for correction. If you try to lengthen, there's always risk of neurologic. And then don't forget the anterior. You know, if you're a plumber and you go to a job, just don't do it all from the back all the time. Think about front and back. Keep that in your toolbox. And then restore the coronal and sagittal balance as much as you can. And then you are going to have complications, but at least in the literature by Mike Kelly, even if you have complications, the patient-reported outcomes are still quite good at 2 years. Thank you so much.
Great. Thank you so much, Dr. Gupta. What a great talk. I had a couple of questions. You know, for those of us who have to do deformities, it's the bane of our existence. Two things come. One is, of course, PJK, because where we end the construct, there are so much stress forces at that level. And I don't know that anyone solved it, but I wanted to ask you if you had, you know, any quick comments as to what you do. And then the second thing is about rod fracture. And so have you transitioned to multiple rod constructs, or do you feel that it's a function of pseudoarthrosis at that level that we get it in the first place? You know, we heard from Dr. Lenke that he's using 6O cobalt chrome for these deformities. What's your take?
All right, so let me answer the first question first, the PJK. It's still an issue. And I think more and more I've started to make sure that I have built enough kyphosis in the upper thoracic spine when I finish the construct. And also make sure you have good lumbar lordosis, because sometimes when you don't have good lumbar lordosis, they're always trying to realign themselves, and that's a problem with failure. So if I'm doing a surgery, I always tether them now. So I'll do UIV, UIV plus one, UIV minus one with fiber tape. And I try to make sure I built enough kyphosis. And I also use the 5.5 cobalt chrome rod. I don't use the 635 in these old people, but if they're quite heavy, then I use the 635 rod. In terms of the preventing the pseudoarthrosis, I'm more apt to use anterior posterior, so that decreases it. But I use that to not only correct the deformity, but also realigning. If you realign the deformity better, you have less chance of strain on the instrumentation and failure. So realigning is very important. For PSOs, I've been using these 4 rod or satellite construct since 2002. Mm-hmm. And I've not seen many failures at all in those cases. So that is important. I don't use 6 rods or whatever. I think the more rods you use, you have less room for bone grafts. So you have to be careful about that. So I don't use that. I use basically 2 rods. And then for most adult deformity patients, I will take an additional rod called the accessory rod, where I will just add it to the previous instrumentation from the thoracolumbar junction to below S1. Because if you look at statistically, all the non-unions happen at the thoracolumbar junction or the lumbosacral junction. So this adds some stability to the construct. So I can use the 5.5 cobalt chrome, add the additional rod, get some additional stability to prevent early rod failure.
Yeah, it's such a good point. You know, we find that rod fractures typically are an L4 to S1 problem. I don't know if you find the same thing. And I always think, well, was it because we didn't pay enough attention to the posterolateral gutters? You know, typically it's at the end of the case, you've done this long deformity correction, you know, spending time laying down bone, decorticating things properly. And, you know, you almost need to slow, not hurry at that point. And I think it's a big deal what you said. Couple of questions from the audience. One was about severe osteoporosis. So in the revision cases, do you wait and have the bone mineral density improve and then, you know, attack the revision, or do you revise and then aggressively treat the bone mineral density? What's your workflow?
Yeah, if you have time to wait, you should. We put them on anabolic hormones, parathyroid hormone, Forteo, for at least 3 months. And I don't think there's a lot of science behind that, because there's a big lag into actually improving the bone density. So if you do it for at least 3 months and a year afterward, that seems to be working. I don't have a lot of scientific data to prove that.
Yeah, I think, you know, it's interesting how everybody kind of says the same thing. 3 months of teriparatide, you know, before they tackle the surgical case. Vincent had a question about PJK.
No, what I was saying is that when you revise a case who has a previous instrumentation and everything, if you can leave the previous instrumentation on the top and not dissect the scar at this level and do all the correction of the lumbar spine, you don't get PJK. Because the PJK, even in severe osteoporosis, so I would try to link to the previous rod as much as possible, and not to expose the top of the previous rods, not to disrupt the soft tissue, the scar, which is the scar which acts as a tension band and which in my mind prevents a proximal junctional kyphosis. So when you revive, you can do the realignment in the lumbar spine without touching the previous instrumentation. If there's no pseudoarthrosis, obviously, I think it's a good thing to link to the previous instrumentation.
Vincent, I think that's a great comment, because if you look at the patients, if they've had a previous AIS surgery and they come to you with a lumbar problem, and you just hook on to the previous rod or the fusion, they will, I have not seen.
Exactly, I'm with you. I've never seen, even in very severe osteoporosis, sometimes people say, oh, you cannot operate this patient because they have too bad osteoporosis. I say, hold on a minute. I'm only going to work in the lumbar spine, iliac screws. It always gives you a good fixation. I'm not going to go touch anything in the thoracic spine, and they don't get proximal junctional kyphosis. You're perfectly right.
The other thing that I think that people don't talk about much is how much kyphosis they have in the thoracic spine. So when people have a lot of thoracic kyphosis, that means their muscles are quite weak, and they, they are not compensating by straightening out the thoracic spine. That's a critical finding. So if they have a lot of kyphosis, you have to make sure you build a lot of kyphosis, because when you put them flat on the OSI table, the thoracic spine flattens out, and you say, oh wow, it looks like good kyphosis, but actually it's not enough. So that's something that you should look at pre-op.
Perfectly right. I've started to put reduction screws to create kyphosis. Okay, so that's because I've overbent my rod, and the resident fellow say, "Why you do that?" I'm making kyphosis. So at the apex of the curve, so you make a large amount of lordosis at the lumbar spine, and you create kyphosis in the thoracic spine. Yes, you're right.